Hey, welcome to a special episode of the Pep Talk. We're going to be talking about mold infection, which a lot of people have and don't even know, quite frankly. We're going to be talking with Jessica Alana today, who specializes in treating people with mold infections, and she uses peptides. We're going to talk about her peptide approach to treating mold infections. Today's show is being brought to you by Regenerative Practices Academy. They are a forward leaning organization bringing emerging therapies and technologies to physicians and clinicians around the world. They actually have a big event occurring in Australia on from November 8th through the 10th. If you want to learn more about that and want to learn about attending, you can go to or email info@regendocs, regendocs.com to learn more about that. And now, without further delay, get my guest on here, the lovely and talented Jessica Alana. How you doing, Jessica?
Hi everyone. Thank you so much, Carl.
Yeah, it's a pleasure. You and I have had conversations already. Your information and your knowledge in this area is vast and proven by the number of people that you've helped. So let's get right to it. You taught me something right off the bat. How do people become infected with mold in the first place?
Yeah, so it's a combination between having the human leukocyte antigen gene defect on chromosome 6 and then actually having a long period of exposure in a water damaged building. Now, a water damaged building is any building that has water damage. And within this water damage, it only takes 48 hours for a microbial colonization to occur. Within this microbial colonization, there can be toxic molds. These toxic molds release mycotoxins just as a part of their daily metabolism. And the interaction between an individual with a HLA, so the human leukocyte antigen gene, and these mycotoxins causes a chronic inflammatory response cascade, which then leads to mold illness, otherwise known as chronic inflammatory response syndrome. So to summarize, it's a HLA defect and mycotoxin exposure from a water damaged building.
And when we talk about mycotoxins, what we're really talking about is mold eats the stuff we eat, and its excrement technically is a toxin, correct?
No, so the mold, it can eat drywall. So it will metabolize the drywall, and just a part of its daily breathing and living, it releases mycotoxins. So mycotoxins, it's not that the mold has specifically gone out of the way to create a toxin and it wants to harm human health. This is just what molds do. So they just metabolize, they live their life, they're an organism, and they go about their day, and they just release mycotoxins. It's just very unfortunate that in some scenarios, these mycotoxins are extremely toxic to certain individuals with the HLA defect. So it's not that the mycotoxin is inherently bad. It's just when combined with a HLA defect in a high exposure, it can lead to chronic inflammatory response syndrome.
When we're young, is the body more equipped to manage it? And then as we get older, it kind of overruns our body? How does that work?
I mean, there's a few different ways that can be answered. So if you think about the HLA, so the human leukocyte antigen defect, this is factory installed at embryo. So individuals, even in embryo, in utero, if the mother is being exposed to a high mycotoxin load, they can pass through the placenta, and they can be causing some sort of chronic inflammatory response syndrome to the baby, to the embryo. Then when the person is born, obviously they will be compounding these mycotoxins throughout their lifetime. So it's more a compounding effect. And then most of the time when the individual reaches maybe 25, maybe 35, 45, depending how they've lived their lifestyle, They start to think, what's going on? I feel so inflamed. And that's when they begin to check. So, in a way, when you're young, you do have more resistance, but it's only because you have less of a toxin load. But you are born with the human leukocyte antigen defect. So, that is factory installed at embryo. So, in a way, yes, you have more resistance, but it's always going to catch up with you because it's not epigenetic, okay? It's a complete genome SNP.
Is there a specific signature for mold infection as far as what the patient presents?
Yeah, so there is something called the symptom cluster analysis, and this is around 35 symptoms that Dr. Shoemaker, who's the original mold doc, he came up with these 35 symptoms and he looked at more than 10,000 different individuals, and it's all peer reviewed and so forth. So this is open source information. So they are considered to be classically 35 different symptoms that if you have 8 or more of these 35 different symptoms, you are considered to have a multi-symptom, multi-system illness. But in my work, and if you speak to any other practitioner, the way that the mold illness and mycotoxins manifest, it's just so wide ranged. It's very hard to actually pinpoint it, which makes the illness very difficult.
Are diseases like, oh gosh, we talked about neuropathy. The country is plagued with neuropathy today.
Mm-hmm.
You said that one of the things that could affect neuropathy is, in fact, a mold infection, correct?
Yeah, so mycotoxins, they really like to be nestled into fatty tissue. So this is the myelin sheath. This is also the brain, the central nervous system, and the peripheral nervous system. So they absolutely love fatty tissue as well. And so does Lyme. So does Lyme disease. But I know mycotoxins a lot more, and mycotoxins definitely are into fatty tissue. They like the cell membrane and they like highly concentrated fatty areas, which is nerves, obviously, myelin sheath.
Do they actually consume the myelin sheath and the fat, or do they just disrupt it somehow?
So mycotoxins are not living. So they're not like a virus or a bacteria or a fungi. So mycotoxins are just kind of byproducts. They're just organic byproducts of mold metabolization. So the mold is like the living colony, is the living fungi, and the mycotoxin is just an organic compound that the mold releases. So the mycotoxin isn't necessarily using the fatty tissue in its own metabolism because it's not alive, so it doesn't have a metabolism to use that for. It just really likes to nestle in because of the specific charge of the mycotoxin. It's drawn into the fatty tissue. You can have a mold colonization in the body. So some people do become colonized with mold. So they actually do have an overgrowth of pathogenic mold in the gut, sometimes in the lungs, sometimes in the nasal passageways as well. I don't necessarily think that this mold uses myelin sheath and so forth to aid its survival and metabolism in the body. I think it just resides in the gut, just like how a candida would. But no, the mycotoxin does not specifically go out of its way to eat the fatty tissue. It just is pulled into the fatty tissue via its charge.
Now, you spoke about Lyme disease. Does Lyme disease share some of the co-infections that mold infections share?
Yeah, so typically, if someone has Lyme disease, they tend to also be HLA compromised, so human leukocyte antigen compromised. And then because of this, they will more often than not have a high mycotoxin load. Because they have a high mycotoxin load, the immune system becomes compromised. This compromisation of the immune system then leads to Lyme and other co-infections having a higher efficacy of reproduction in the body. So most of the time, the priority if someone has Lyme disease is to lower the mycotoxin load, sort out the immunosenescence, and then actually attack the Lyme and all of the co-infections.
What about fibromyalgia? That's a mysterious symptom-driven disease. Is there any link to mold infection?
Fibromyalgia and chronic fatigue syndrome in the integrative and naturopathic world are highly linked to mold illness. Yes, so we actually believe that chronic fatigue syndrome and fibromyalgia are basically dead end blanket terms that allopathic medicine will give someone just when they don't know really what's going on. And if
Mhm.
you actually test those people for mycotoxin load, for Lyme, for HLA, more often than not, you will find that these people have very high mycotoxin load, they're HLA positive, and they may or may not have Lyme too. So there's a huge link there. So I advise anyone who has fibromyalgia or chronic fatigue syndrome to not accept that diagnosis and take a step further.
Is fungal infections on the skin, whether it be uh, athlete's foot or any of these, or in women's cases, maybe even a yeast type infection, are they indicative of an environment that is going to allow mold to run rampant?
I mean, anyone who has reoccurring fungal infections, whether it's in the vaginal microbiome or on the skin microbiome, this is suggestive of immunocompromisation and a possible stronger colonization within the gut. So, yeah, I mean, you typically see a lot of candida and yeast alongside a mold colonization and mold illness. So, yeah, I would say that's correct.
Is mold load tested in blood, in serum, or in saliva, or how do they actually test to see what your preponderance is for an infection?
So there's a few different tests. The first one is the original Dr. Shoemaker lab panel. This is done on LabCorp and Quest, and you have to be very specific with the codes. And I have this physician's order sheet. If anyone would like to contact me, I can send that to you freely over email. You can take it to LabCorp and Quest, your PCP, your MD, and you can have all of these tests done. So this will test you for the HLA defect, and it will also test you for other markers such as C4A, MMP9, leptin, TGF beta 1, alpha MSH, VIP. These markers are indicative of chronic inflammatory response syndrome. The second test that you can do is known as a mycotoxin panel. This is a urine panel, and it basically tests for the concentration of mycotoxins in your urine. Okay. The third test that you can do is just a very simple HLA cheek swab to tell you if you do have the HLA defect.
And I want to put this up. Your website is Jessica Alana, but it's spelled JESSICALANA.com. What is the email address that people can email you if they want to request that panel information?
It's just Jessica at my domain name. So Jessica at jessicaalana.com. So how it's exactly spelled.
Okay.
So it's
Excellent.
the same A for Jessica and same A for Alana.
Right. JESSICALANA.com for anyone who's just listening to the podcast. You know, it's a very popular thing in the southeast of the United States to use something called a swamp cooler. And these are in the very, very dry, arid climates, instead of using air conditioning, they use swamp coolers, which basically adds moisture to the air. I've
Okay.
always wondered about that approach and whether or not those homes tend to develop mold to a greater degree because the home is always moist, so to speak. Any thoughts on that?
I mean, so in the mold world, you actually want to keep your humidity below 40%. So you actually want to buy machines that help you keep the humidity below 40%. So I can't imagine in any way pumping humidity into your home in any way is going to help reduce colonization of mold. I would advise against that. In the very least, I would not be pumping moisture into my home.
In the treatment of, and we're going to talk about treatment now in a couple minutes, but before we get into that, in the treatment of mold overload, is diet important? Does diet play any role at all? Since now we know you don't get a mold overload because you ate some moldy cheese. It's because you have been living in an environment where mold has been raining on you. You've been breathing it in, you've been touching your nose, and it literally it becomes a part of your environment. So, does diet play any role in the management of mold infection?
So I would say that if an individual already has chronic inflammatory response syndrome and they have a high mycotoxin load from being exposed to a water damaged building, and they consume moldy coffee or moldy cheese or moldy grains, this is going to cause a further small antagonizing insult for that day. So they might feel worse on that day, but it's not the main driver behind the chronic inflammatory response syndrome. In terms of treatment, diet is not how you got into it, and it's not going to be how you get out. Of course, I always advise for a anti-inflammatory diet, but it's really going to not move the needle. I mean, diet alone cannot reduce immunosenescence. Diet alone cannot help the Th1, Th2 cells. Diet alone cannot turn on T cell re-exhaustion. Diet alone cannot help the NK, the natural killer cells as well. I would say the main thing is to reduce gluten, reduce alcohol, reduce dairy if that's inflammatory for you, and just have a whole foods diet. But it's not the treatment for mold. I know there's a wide community of people who've gone on carnivore diet to help with their chronic inflammatory response syndrome. But carnivore diet, it's a short-term restrictive tool that you use while you're also getting treatment. And then after you finish treatment, you should be able to go back to a full range of foods that you can eat. So having the carnivore diet, it does help, but it's not the treatment that you go to.
Fascinating. What role does mold have on affecting the mitochondria?
So mold can affect the mitochondria in different ways. It can actually encourage the mitochondria to enter cell danger response. So the mitochondria turn from their M2 oxidative phosphorylation state into their M1 pro-inflammatory state. So they go from being power plants to actually inflammatory battleships. Also, the way that the mitochondrial membranes work are also highly inhibited by mycotoxins. So mycotoxins can not only damage the cell membrane, but they can actually enter the cell and damage the inner and outer membrane of the organelles, one of these organelles being the mitochondria. So yeah, the mycotoxins can lead to cell danger response, and they can also cause damage to the mitochondrial membranes. All of this combined and way more mechanisms as well can lead to hypometabolic mitochondria, which is often the root cause of the chronic fatigue that people with mold illness are feeling. At the same time, this also inhibits steroidogenesis as well. So you have lack of pregnenolone, which then goes on to the other steroids. You have lack of growth hormone, IGF-1. You have a lack of hormone signaling as well. So it's a very complex picture when it comes to the mitochondria.
Dr. Thomas Seyfried wrote a groundbreaking book called Cancer as a Metabolic Disorder or Disease. And much of his early research showed, because what they did was they took the mitochondria out of a cell that was dangerous and put it in a healthy cell, and vice versa. And what they determined was that the mitochondria switches to desiring glucose as an energy source, and anaerobic respiration occurs, and this is what turns on the onco gene and makes a cancer cell. And I think back, I did a show probably in 2007, 2008, a study that showed a link between mold and cancer. You speak about that a little bit?
I read the summary of Professor Seyfried's book in 2021. So I used to play a large role in London's most established hyperbaric oxygen clinic. And I worked there for 2 years. And we would see a lot of cancer patients who were getting into hyperbaric oxygen for the treatment of cancer. And we had very good success. So my mentor who helped me at the clinic, she actually got me into Professor Thomas Seyfried's work, and I read his summary book. And I'm familiar with the anaerobic respiration of mitochondria. And it's basically, they go back to eons ago when they were only a single cell organism and they weren't part of a larger group of organelles, and they start to only metabolize at the level of pyruvate, I think. I'm not too familiar. I need to shape up on this knowledge, but I know that mold, in that way, in that sense, it can indirectly lead to cancer. And also, some of the molds as well, like Sierra Leone, are actually xenoestrogens, and these can actually lead to cancer-forming compounds too.
Yeah, fascinating. So once you've been tested and you establish that, I guess you have a numerical value of your mold load or your mycotoxin load.
Yeah, yeah.
Once you've established that you are, in fact, infected, how long does it take and what are the steps to correct it?
Mm-hmm. I mean, so ideally, what you're looking for is either the full Dr. Shoemaker panel, which I always encourage people to get. So inside the USA, this is very easy to get. It's very accessible for people to get a LabCorp and Quest panel done. Okay. Outside of the USA, it's a few £1,000s, so it's expensive. So more often than not, you're settling for the mycotoxin urine panel and the HLA swab. So once you've confirmed HLA, so you do have the human leukocyte antigen defect, and you either are showing signs of chronic inflammatory response syndrome from the blood panel, or you have a high mycotoxin load shown from the urine panel, then it is a lifelong decision to actually detoxify from mold and be aware of your environment. So you have the treatment side of things, and then you have the environmental side of things. Ideally, you need to work with people on both ends. So you're looking at getting your whole house remediated or moving. So the recovery is in the remediation and removal from exposure. And then when you look at treatment, this would be someone like myself or another practitioner. We can use a wide range of treatments, like peptides, for example. There's also binders, there's also refeeding therapies, there's phospholipid therapy, there's ozone therapy, there's low dose naltrexone, there's colloidal silver. You have to work on the ears, nose, and throat. You can use suppositories, you can use enemas, you can go into parasite cleansing. You can take it really, really far. But ideally, there's two avenues. So once you have confirmed HLA defect and either high mycotoxin load or inflammatory response syndrome, you need to look at your environment and your treatment, and those obviously branch off again there. So the process, I mean, it can take 3 to 6 months to go from completely unknown mystery into I'm feeling better. And then still after that 3 to 6 months, you need to have a constant eye on the ball when it comes to your mold load. You know, if you stay in a hotel for a long time that has a very high mycotoxin load, you'll start to feel really down again. So it's a lifelong skill that people with this HLA defect need to learn.
It's fascinating. Is there any reason to think that the defect was part of our evolutionary process for some reason that we have this defect? Like when I
Um,
look at evolution, I usually can go, "Oh, now I understand why." Is there? Do you look at this ever and think, "Oh, I understand why these people have this defect"?
that's actually a good question. I have not considered the evolutionary basis of this HLA defect. I have not. I haven't pondered that. I can look into it. I'm not too sure.
Mm, okay, okay. Let's talk about peptides. Peptides are wonderful. They are basically cellular to cellular, cell to cell messages.
Mm-hmm.
They can develop and deliver information that makes a cell change and fix things. So, what are your go to peptides? And do you introduce peptides first before doing any of the other, um, like some of these uh, mold arresting drugs are harsh on the liver? Do you use peptides first before you start moving to things like that?
Yeah. So if someone comes to me and they have not been diagnosed with HLA or a high mycotoxin panel or the inflammatory blood markers, but they feel so inflamed, they have brain fog, they have all of the symptoms, I will immediately put them on a peptide protocol. Because even though I frame peptides around mold illness and chronic inflammatory response syndrome, peptides are actually categorized in different categories. So I can put someone who shows all the signs of brain fog, of immunocompromisation, of leaky gut, of chronic fatigue. I can just put them on a peptide therapy protocol in these specific categories. So even if someone has not been diagnosed, I can work with them on peptides. But if someone has been diagnosed, and yes, the first thing I'll do is I'll run them on a peptide therapy protocol for 4 to 6 weeks. Because some people want immediate relief. Some people need immediate relief, and the peptides can do that regardless. They may not have mold, they may have very high EBV or CMV, and still, if you put them on TA1, thymolin, epitalon, BPC, LL37, it's going to help the EBV and CMV. So peptides are very unanimous, so I really like them. But yes, I will always put someone on 4 to 6 weeks of peptides.
Then the more aggressive approach, like ketoconazole and drugs like that, are they effective at helping people get their mold infection under control?
So usually it's maybe 4 to 6 weeks of peptides. Then you look into binding. So you can use natural binders or you can use the peer-reviewed prescription binder cholestyramine. Now, when you come on to antifungals, which would be nystatin, itraconazole, and fluconazole, there's a few different camps. So the original Dr. Shoemaker mold doc, he strongly advises against the use of antifungals. Okay. But then there's other doctors like Dr. Neil Nathan and Dr. Brewer who actually would like you to use antifungals. This then trickles down into the community. So there's people who've gotten better just from using binders like cholestyramine, and then there's people who just get better from using antifungals. So what I like to do, I like to inform the client of all their options, give them all of the evidence, tell them that there is this political divide within the mold community, and I would like them to choose because it's a pilot co-pilot relationship. They also have to do their research. If they'd like to use the antifungals, I can guide them through, or we can actually phase it in. So we can use cholestyramine, see if they get any better. If they don't get better, then you can begin with nystatin. Nystatin is a very, very gentle antifungal that's only localized to the gut. So you can kind of work your way up.
So we're focusing on the gut a little bit here. Is that where the majority of mold resides when you have a mold infection, or is it in tissue, just all over the body?
So the mycotoxins, they can be everywhere. Okay. And then the actual mold colonization tends to be in the gut.
That makes perfect sense. That makes perfect sense.
Yeah.
The mycotoxins are delivered systemically because the mold lives in the gut. So
It can happen. It can happen. Dr. Shoemaker is more on the side that mold will not colonize. But then there's a very large community of doctors and obviously patients that have proven to have mold colonization growing inside of them. So it's a case-by-case basis.
certain things, certain fatty acids, and certain other things like dimethyl sulfoxide have been shown to destroy the membrane or the cell wall of mold.
Okay.
And it does it rapidly. So Herxheimer is a reality. The first week, even people feel horrible. They feel like they have the flu, but it's because there's so much of these dead mold bodies, if you will, floating around the system that the body can't get it out fast enough. Have you found any success with any of the free fatty acids or DMSO?
I have not used these actually in practice. This is the first time hearing about fatty acids and DMSO being able to do that. So I need to look into that further. So thank you.
I don't think DMSO is advised to be taken orally, although it is
Okay.
as a cancer delivery system, as a vehicle. But nonetheless, I've always wondered about DMSO. Seems to have a pleiotropic effects and benefits in the body. Okay, so I want to put your website up again because I want people to be able to go and find you should they feel like they want to reach out to you. JESSICALANE, Jessica Alana, ALANA, I'm sorry, .com. You are also going to be one of the teachers in the Regenerative Doctors Academy program, correct?
Yeah, I'm super excited about that. So I will be releasing a series of lectures that are very specific for peptides for mold illness and chronic inflammatory response syndrome. So it's going to be very science backed, almost like a university lecture style. So me just in the corner with the webcam going through a series of slides, fully referenced, so you can all learn about peptides specifically for mold illness and chronic inflammatory response syndrome. And this will also be reflected in my talk in Australia as well.
So if you're a clinician, you're a physician's assistant, this organization is for you, regendocs.academy, because they are going to be teaching. You'll get credit, continuing education credits for taking these courses, but you'll also be equipped to start to use these therapies with your patient. They give you an end-to-end turnkey approach, a curriculum. They even give you information to train your staff on how to speak to this with your patients and so on. RegenDocs.academy is like nothing you've ever seen before. I know there's organizations out there claiming to teach people about peptides. While they're going to teach you about peptide therapies that you can then prescribe, they're doing some stuff that's amazing. For instance, like guided hallucinogenics for people who want to experiment with psychedelics to correct major depressive disorder. I brought Dr. Samuel Denmead to them. He's going to be teaching you, doctors, physicians, assistants, and so on, how to treat prostate cancer by giving men testosterone. Men hate prostate cancer therapy because it's ADT, androgen deprivation therapy. It wrecks them. It makes them spontaneously diabetic. They have all sorts of health problems, and it doesn't really get rid of the prostate cancer. Dr. Denmead came on Superhuman Radio 3 different times over the 18 years I was on the air, and he is curing the most aggressive prostate cancers by giving men testosterone. The only place you're going to be able to learn how to do that is at regendocs.academy. So if you're looking to offer your patients a wider variety of therapies that they're not going to be able to get anywhere else, but more importantly, that actually work, regendocs.academy is where you want to go today. And obviously, you'll be able to then work with Jessica Alana to learn how to provide mold recovery with your patients as well. I know you don't like to do podcasts, so I feel special.
No, I like them. They're okay.
They're okay. And so is getting your teeth drilled. It's okay.
Yeah,
Listen,
it's okay.
I want to thank you so much for what you're doing, what you're teaching people.
Oh, thank you so much.
There's a lot of people out there who go to the general medical orthodoxy and they're given antidepressants, and drugs that they really don't need, because I don't think most mainstream doctors think mold infestation is even a thing. That's the reality of it. So thank you for doing this. Thank you.
Oh, you're welcome. And thank you so much as well. Thank you.
So there you go. We'll have more shows coming up. Stay tuned. Again, regendocs.academy is the place to go. Thanks for watching. And please share the show. You never know whose life you're going to change, even if it's just one person. Share the show. All right. Thanks for being here today. Thank you.